Good morning all the respected delegates, faculties who are present today in the second annual conference of Association of Clinical Pharmacologists in India. So from Kolkata, we are really privileged to host you all. Welcome all the online delegates, and we'll start today's session with a very interesting workshop on therapeutic drug monitoring, and we are really privileged to have Professor Smita Pattanaik Madam with us. She is the course director for this particular workshop, and may I request Professor Shantanu Kumar Tripathi to felicitate Madam, and we'll start the workshop straight away. Madam, please.
It's a great privilege to welcome Professor Smita Pattanaik, who needs no introduction, and she will be the course director of this particular symposium on therapeutic drug monitoring, and she is a professor at PGI MER Chandigarh. And welcome, Dr. Pattanaik. So now the stage is yours.
So I welcome you all to this symposium. At the outset, I would like to thank the organizing team, especially Dr. Sampu, to invite and keep this as an introductory thing. I wish there would have been more participants, but I am really thankful to my online participants who are present to hear this. And I also sincerely thank Dr. Sandhya and Dr. Sumit Matthew from CMC Velo, Dr. Sandhya from JIPMER, who kindly accepted my proposal and also have consented to present in this symposium. And the purpose of this symposium is nothing but to hear from the experts, those people who are doing the TDM in the respective therapeutic areas. And this is definitely a very basic and preliminary kind of a work that preliminary kind of information that would be provided to the participants in terms of the level of complicatedness we would try to avoid, or we would try to avoid the other issues. We'll try to do the basics mostly, and people will share their experience, and you're welcome to ask questions. Please ask questions. That's my request to you, so that we want to make it as an interactive thing. And this is the
Madam, need to share the screen.
So I had the PDF document.
So can you please, Clarnet, please let us enable to share the screen first from this conference room. Yeah. Sir, no.
So this is how will be the flow of the presentation. Basically, we will I hope everyone is able to see this. So this is the schedule of presentation. First, Dr. Sandhya will take on the anti-epileptic drug, and we are all set. We have welcomed her already, and she's here to join from JIPMER. Then I would give a brief overview. Good morning, Dr. Sandhya.
Good morning, madam.
Ma'am, hello?
Yes, yes.
Yeah, ma'am, please try to increase the volume. Actually, it's too low.
From my side?
Yes.
Okay.
Sound is coming properly, but it's too slow. So
Okay.
just need to increase the volume.
Okay. Is it better?
Yes, ma'am.
Okay.
Absolutely.
Okay. Wonderful.
Thank you.
Okay. So next we will be having the TDM of immunosuppressant drugs, and though CMC Vellore has the maximum in sort of, I can say that, experience, but Dr. Sumit Matthew would be presenting the TDM of antimicrobials, and we will be taking on the TDM of immunosuppressant drugs. Now, in the end, Professor Tripathi will sort of give us a overview that why TDM has not picked up the way it should have picked up in this era, in the sense that India is no more considered a developing country. You might all know that, because there is a lot of development in other areas of science, but somehow TDM has lagged behind. So Dr. Tripathi will take us through the reasons or the constraints that TDM is currently facing in this country. And in the end, we will have a short panel discussion, kind of a thing, where we would take up your questions and also try to understand what all we can do to make the status of TDM better in our country. So without much delay, let me invite Dr. Sandhya. Dr. Sandhya is an additional professor in the Department of Clinical Pharmacology at Jawaharlal Nehru Postgraduate Institute of Medical Education and Research, JIPMER, we fondly call it as JIPMER Puducherry, and she will take us through her journey of anti-epileptic drug TDM. She has many other accolades to share. She heads a lot of committees in JIPMER. She is into the administrative committees, she is into the ethics committee, and she runs a very active clinical pharmacology program at JIPMER. So Dr. Sandhya, over to you. We are eager to listen to your presentation. Thank you.
Yeah. Thank you, madam. Thanks for the introduction. Just a few seconds. I'll share my screen once again.
Yeah. So I will unshare, right? Yeah. She can share. Yes. Wonderful. I think she can share now, right?
Is my screen visible?
Yes, Dr. Sandhya. Yeah.
Okay. Yeah.
Yes, ma'am.
Yeah. So at the outset, I would like to thank the organizing committee, Dr. Shantanu Tripathi, Dr. Shambho, and the director of this symposium on TDM, Dr. Smita, for giving me this opportunity to be one of the resource persons and give a lecture on therapeutic drug monitoring of anti-epileptic drugs. So, for the need of better internet connectivity, I will just switch off my video while I start my presentation, and I will join back at the end of my presentation. So, moving on to my topic, in the next 40 to 50 minutes, I will be giving you an introduction to TDM, the various indications and the drugs requiring TDM, the clinical application of TDM, especially with respect to my topic, that is anti-epileptic drugs, and how do we do TDM in special population when they take anti-epileptic drugs, the use of pharmacogenomic knowledge to decide the dose, and the recent advances in TDM. So moving on to the first slide of my talk, let me start with a case scenario. An 87-year-old man came with 1 week history of feeling uneasy with unsteady gait and episodic confusion. He was on phenytoin for epilepsy for the last 2 years, which occurred after stroke. However, he has been seizure-free for the last 2 years. But currently he has developed intermittent dysarthria and dysphagia along with bilateral nystagmus, intentional tremor, and ataxia. When a repeat CT scan was taken, it did not show any change from the previous CT scan of the head. So the treating physician suspected phenytoin toxicity and asked for phenytoin concentration, but however, the TDM showed the phenytoin concentration is within the normal range of 10 to 20 microgram per ml. It was within range. The concentration was 18 microgram per ml. So now there's a confusion. When the plasma concentration of phenytoin is within the normal range, why is showing features of phenytoin toxicity? What could be the cause leading to this presentation and how the patient should be treated? So the answer to this scenario is available somewhere down the slides while I present my topic. So with this, let us move on to what is TDM and what are the uses of TDM. Okay, what is TDM? In simple definition, it is nothing but measurement of drug level to decide the dose of a drug for an individual patient. So when we give drug to an individual patient, after some time collect the blood sample and see the concentration of the drug in the plasma or serum, and then see whether it is within the therapeutic range and should we change the dose or keep the same dose to the patient while we decide the next dose. So this is the basis of therapeutic drug monitoring. So why we have to do this and for what kind of drugs we will do TDM? We will do TDM only for those drugs which have got a definite relationship between dose of the drug, the plasma concentration of the drug and pharmacodynamic effects. If these factors have some association between them, then only we can do TDM. A drug should have association between its dose and the pharmacodynamic effects. So assuming when we give a drug, after it reaches a particular concentration in the plasma, that is known as a therapeutic range. If it produces therapeutic response within that range, then we just want to check whether the plasma concentration is within this range or above the range, which can cause toxicity, or below the range, which is not effective. With this knowledge, we can adjust the dose to maintain the plasma concentration of the drug to be within this targeted therapeutic range, so the patient does not experience either toxicity or treatment failure. So the very basis of TDM is based on the assumption that there is an association between the dose given, the plasma concentration of the drug achieved, and the pharmacodynamic effect it produces. So can we do TDM for all the drugs? Can we measure the plasma concentration and adjust the dose for all the drugs? No, that's not possible. Only for few drugs we can do TDM. So what are those drugs? What are the indications? Those drugs which have got narrow therapeutic index, zero order kinetics, which show wide variation in the metabolism of the drug, drugs which undergo lots of interaction when multiple drugs are given, in patients with hepatic or renal impairment, if the particular impairment is known to affect the metabolism of the drug or elimination of the drug, in the presence of poorly defined clinical endpoint, or if there is treatment failure. In these if there are these indications, then we can do TDM for such a drug. Sometimes we also do TDM to find out the adherence of the patient to the treatment. Okay, so usually if you look at the drugs occurring TDM, anti-epileptic drugs, immunosuppressants, mood stabilizer like lithium, antiarrhythmics like amiodarone, digoxin, aminoglycosides, and some of the antibiotics are the drugs which require TDM, which will be covered by subsequent speakers. So let me focus on my topic, anti-epileptic drugs. So most of the time TDM is done for the commonly used anti-epileptic drugs in our setup like phenytoin, phenobarbital, carbamazepine, valproate, etc. So why do we do TDM for these anti-epileptic drugs? Now coming back to the indications for TDM. So drugs like phenytoin has a narrow therapeutic index. It follows saturation kinetics. After a particular level, it starts, initially it follows for first order kinetics, but after a particular concentration, it starts following zero order kinetics. So we don't know how much will be cleared, how much will be eliminated. And drugs like phenobarbital, carbamazepine, and valproate, they can show wide variation in their metabolism. And these drugs have drug-inducing and drug-inhibiting properties, so there can be lots of drug interactions when they are taken with other drugs. And if the patient happens to have hepatic impairment, again, most of these drugs which are metabolized in the liver may have a different effect. And epilepsy, as we all know, has a poorly defined clinical endpoint. We don't know when do we say the patient is treated. Like, for example, how seizure-free period for how long can be considered as the patient has come out of seizures, or if a seizure occurs, if it is due to the disease or if it is due to treatment failure. It is very difficult to decide when seizure occurs in a patient after a long time, after a long seizure-free period. So the anti-epileptic drugs fits into all the criteria for doing therapeutic drug monitoring. That's why we do therapeutic drug monitoring for anti-epileptic drugs. Also to ensure adherence to the treatment, because most of these patients, since this is a chronic treatment, if there is seizure-free period for a long time, these patients tend to stop taking the drugs by themselves, which is not good for them. So to check adherence also, sometimes TDM is done in these patients. Okay, now how do we do? We have let us say we have patients who are taking anti-epileptic drugs, but then how do we do TDM? So the most important thing for TDM is doing a sample collection. We need to collect the blood sample for doing TDM. So when do we take blood sample? Can we take blood sample immediately after taking the first dose or second dose or third dose? We have to wait till the patient reaches the steady state. Not only for anti-epileptic drugs, for any drug for that matter, TDM can be done only after the steady state level is reached. So depending on the off-life of the drug, we need to wait for 4 to 5 off-lives for the patient to reach steady state, so that we can collect blood sample for doing TDM. If the loading dose is given to achieve the steady state, then we can do TDM immediately also. So which level to be taken, trough level or the peak level? So for knowing the treatment efficacy as well as adherence, trough levels are preferred over the peak levels. What is trough level? Trough level is nothing but taking the blood sample just before the next dose. So this will help us to know whether the patient's drug concentration is within the therapeutic range. So let me show this with the help of this graph. So once the patient has reached the steady state concentration after the drugs are given for 4 to 5 off-life, then there is a particular therapeutic range within which the plasma concentration will be maintained. So before the next dose, just before taking the next dose, if we take the sample, then we will be able to know whether this is within the effective concentration. So when do we take peak level? So if we suspect toxicity, then we can take peak level. But if the patient is already in so much of toxic symptoms, he has come with toxic features, we can take sample at any time. So generally we do trough level plasma concentration measurement for assessing adherence or treatment failure. Okay, after collecting the samples, what do? We go for analytical methods. We can analyze the plasma concentration of the drug using any of the equipments like HPLC, ultra performance liquid chromatography, UPLC, or LCMF-MS, or even using spectrophotometry or 2D. We also have got multi-drug analyzers like tabletop multi-drug analyzers. We are using kits. We can analyze few samples. So depending upon the availability of the equipment in a particular institute, we can choose any of these methods for analyzing the plasma concentration of the drug. So while doing this analytical analysis, what are the issues which can arise? We have to be very sure the accuracy, precision, reproducibility, repeatability, and robustness of the method which we follow is good, so that we can ensure the quality of the results. Though most of our labs don't go for laboratory accreditation, it's always better to have accreditation, though it's an ideal requirement. Having a laboratory accreditation is always good to ensure that whatever results we are giving is accurate and dependable. Okay, now after analysis, what do we find? We find out concentration of the drug. So this table shows the therapeutic range for drugs like phenytoin, carbamazepine, phenobarbital, and valproate. So if the plasma concentration of the drug in the patient is within this range, then we consider the patient is having normal range, is less likely to develop toxicity or treatment failure. So that is the conclusion from the therapeutic concentration. So in our lab, we have HPLC, LCMS as well as UPLC. Initially, maybe around 10 years before, we were using HPLC for measuring all the anti-epileptic drugs. Right now, we are using LCMS for measuring valproate and immunosuppressants, and UPLC for measuring phenytoin, phenobarbital, and carbamazepine. As I already said, depending on our feasibility and availability of the equipment, we can choose any of the equipments. Or if we can't spend so much money, we also have small multi-drug analyzers, where we can do samples, few samples using kits for saving time as well as money. Okay, so this is our requisition form. So the physician who asks for TDM has to fill this form. They have to mention, I don't know whether you are able to see this properly. So the patient's name, diagnosis, which drug they are taking, what's the drug history, when the treatment started, when was the last dose given, what do they need this test for, when the sample, is it for toxicity or treatment failure or adherence, when the sample should be collected, should it be at trough or peak level. So all these queries will be there in the requisition form. Though most of the time this will not be filled completely, but generally at least 90% will be filled properly. So this is the report form. Once the results are ready, the report will be given in this report form with the standard normal range. And here the values what I find from the analysis will be given. And this is also mentioned at the end. The therapeutic ranges are given in parentheses. However, it varies depending upon the diagnosis and clinical condition of the patient. So the clinician has to correlate the concentration with the clinical condition of the patient. Okay, so if we look at the monthly reporting of TDM on anti-epileptic drugs in 2022 in JIPMER, we had a total of approximately around 150, including phenytoin, phenobarbital, carbamazepine, valproate, with more TDM for valproate. Actually, this is less as compared to the previous year, 2021 and before 2020, as compared to the values before 2020, this was less. Probably the 2023 values, when we check, we might have got the values which we used to get before 2020. Okay, now having said this, so what are the applications of TDM? As I already mentioned, this is mainly for individualizing the therapy before initiating the therapy, or after initiating the therapy. If we want to change the dose, again we need to do TDM to see whether the plasma concentration is maintained within the therapeutic range, to avoid toxicity, to monitor adherence, and whenever seizure occurs, to see whether it is due to treatment failure or is it because of the disease. Also to monitor drug interactions if the patient is on multiple drugs, especially if they are on ATP or some other drugs which are known to interact with anti-epileptic drugs. Okay, having said all these things, apart from whatever factors I have mentioned, the plasma concentration of the drug may also be influenced by other factors, like one is drug interaction, the other one is if you look at the pharmacodynamic variability, it could be due to variations at the drug receptor level, genetic factors, or development of tolerance to the drug. So in these conditions, how do we use the TDM value? How do we proceed about with deciding the dose? So there is also a concept called a priori TDM. What is this a priori TDM? So here we identify the subpopulations of patients with different dosage requirements. From there, from the demographic data and other pharmacogenetic characteristics which are available in the literature or from our previous study. For example, if what should be the initial dose for patients with hepatic impairment, or what should be the initial dose in children below 6 years or 5 years. So identify subpopulations and try to find out the dosage requirement using population PKPD models. So we can determine the initial dose based on the available data using population PKPD models, and then start the initial dose. That's the a priori TDM. So we do some sort of analysis even before giving the first dose, and then give that dose and see whether this is within the therapeutic range. Okay, so what are these special populations? One is children. As I already mentioned, the clearance of anti-epileptic drugs is different in children as compared to the adults. The clearance is very high, resulting in less elimination of life, especially in children between 6 months to 6 years of age. As a result, they require a higher dose as compared to the older children, adolescents, and adults. In this condition, TDM plays a major role in maintaining the therapeutic range, and a priori TDM plays a major role in predicting the optimal therapeutic doses for this group. Similarly, for patients with hepatic impairment, most of these anti-epileptic drugs are highly bound to serum albumin, and this hepatic impairment can lead to reduced serum albumin, resulting in elevated free concentration of the anti-epileptic drugs, which could lead to toxicity. Though we do the plasma concentration of the drug, it may be within the therapeutic range because this is the total concentration. But if we measure the free level may be high in these kind of patients. This is like this partially answers the scenario which I had shown in the first slide of my talk. So there also the old man had presented with the features of phenytoin toxicity, but the TDM showed phenytoin concentration within the normal range, that is 18. It was well within 10 to 20 microgram per ml. It was 18 microgram per ml. So they were not able to decide whether it is due to toxicity or some other reason. But if the history of that the person was looked back, he was he was not feeling well. He was having dysphagia for the last few days. So this could have resulted in his this undernourishment could have resulted in low albumin level. So if the albumin level was checked, the albumin level was found to be low. So again, the free level of phenytoin was done, and it was found to be high, which described why he was showing phenytoin toxicity. It was because of low albumin level, free phenytoin concentration was high, and this resulted in phenytoin toxicity. So sometimes even if the therapeutic concentration, if the concentration is within the therapeutic range, we need to be looking for other factors which could be responsible for causing the toxicity. Similarly, one more thing which we should keep in mind is use of alternate system of medicine. All of the systematic reviews have found out that South Asians use alternate system of medicine more than any other population. So one of the interesting studies from KEM long back in 1992 has found that 2 cases of generalized tonic-clonic seizures with well-controlled serum phenytoin levels suddenly showed seizures after seizure-free interval. So upon taking history, they found that both these patients were taking an alternative Ayurvedic preparation called Shankapushpi, which is also known to have anti-epileptic effect. Subsequently, they have done animal studies in rat and found that with one dose of Shankapushpi, nothing happens. But when multiple doses of Shankapushpi is taken, it reduces the phenytoin concentration, leading to treatment of phenytoin. So it also has an anti-epileptic effect. It has got some sort of drug interaction with phenytoin, and hence clinical combination of this drug SRP with Shankapushpi has to be avoided. And the patient should be advised not to take alternative medicine when they are taking these anti-epileptic drugs, because this could lead to drug interactions, unknown drug interactions which are not documented in the literature. So we also need to look at these factors. So what are the practical issues which we come across while doing TDM? So whenever the sample is sent for TDM, the physicians expect the value to be given at least within 24 hours of giving the sample, because it plays a major role in critical decision making. However, there are few difficulties like feasibility issues in giving the results immediately. For example, even in our setup, it will take around 2 to 3 days depending on the availability of the sample. If more samples are there, then the results will be available on the same day. But if only 2-3 samples are there, then they will wait at least for some 78 samples to be collected. This is mainly to avoid wasting the machine run and consumables. So it depends. If we get more samples, the results will be given immediately. If the samples are less, then they have to wait. So this is some of the practical issues which we face in our setup. Apart from that, we also should keep in mind the reason for variation in therapeutic range could also be due to the genetic polymorphisms involved. Even though the patient is taking the drug properly, even though the dose given to him was appropriate, if there are few genetic polymorphisms, they may have an effect on this plasma concentration. So some of the studies, let me show some of the studies done from our own center. So this study, which was done to see the effect of CYP2C9 genetic polymorphism and undernourishment on free phenytoin concentration in epileptic patients, found out both undernourishment as well as CYP2C9 allele variant elevate the free phenytoin concentrations individually as well as in combination, and this additive effect of increasing free phenytoin level has can cause phenytoin toxicity with an odds ratio of 37.3. It's quite high. When both undernourishment and CYP2C9 allelic variant were combined, the odds ratio for developing phenytoin toxicity was found to be very high. Similarly, one more interesting finding was like the effect of NAD2 gene polymorphism on phenytoin toxicity. This study found out when these anti-epileptic drugs are given with anti-tubercular drugs, INH, which causes minimum inhibition of CYP2C9 enzyme, with the CYP2C9 enzyme is one of the primary metabolizing enzyme of phenytoin. But however, in some of the patients, they found out this INH-induced phenytoin toxicity was not due to the involvement of CYP2C9 enzyme, which is involved in metabolizing phenytoin, but it was due to inhibition of CYP2C19 enzymes, which is in the alternative pathway of metabolizing phenytoin when the phenytoin level exceeds 10 microgram per ml. So, this study found out that NAD2 gene polymorphism results in increased phenytoin level. As a result, phenytoin follows saturation kinetics, leading to phenytoin toxicity. So this study found the plasma phenytoin level was more than 15 microgram per ml in all patients with phenytoin toxicity, suggesting saturation kinetics of phenytoin due to the indirect effect of NAD2 polymorphic gene polymorphism. So when we don't find any reason for toxicity, even if the drug level is within the normal range, normal therapeutic range, then these polymorphisms also could be looked for. Though in our research over setup, it's not always possible to see the genetic polymorphisms and their effect on therapeutic range. But if we have the facility, it is always good to look for the genetic polymorphisms also. Okay, so now moving on to the recent advances in TDM. What are all the recent advances? How do we assess the plasma concentration of the drug, especially phenytoin? There is an interesting concept from your PhD thesis called microdialysis. In microdialysis, what do? They use the principle of dialysis for measuring drug concentration from brain tissues. So the concept is any substance present in high concentration in the brain's interstitial tissue diffuse into the dialysis perfusion fluid, and this perfusate known as microdialysis can be collected to assess the concentration of phenytoin in the brain. So how do they do it? They use a microdialysis catheter. So it can be inserted into to collect the perfusion from the brain interstitial tissue, and this can be done as a bedside therapeutic drug monitoring to measure the phenytoin level. So the advantages of this is the drug concentration in this compartment does not vary. We can do continuous sampling and any number of samples can be collected, and unlike our blood samples, sampling is very fast, and we can do the analysis within a short time, and those can be adjusted. Usually here the collection time is between 10 to 12 minutes for 20 to 25 microliter sample value. So we can decide the concentration of the drug in the brain and decide on the dose accordingly. But the disadvantages are it is a very intensive process, time consuming. A skilled person has to be dedicatedly present in the scenario to measure the drug level at frequent intervals. Other methods of collecting blood other than collecting the usual blood sample is like dried matrix microsampling, where we can take either dried blood spot, dried plasma spot, dried serum spot, or volumetric absorptive microsampling. The advantages of this dried matrix microsampling is less volume is sufficient. With finger prick blood, we can go for dried blood spot, and this can be even done by the patient themselves in their house, and they can give the dried blood spot for analysis to the lab. And another easy method of collecting the blood sample is capillary microsampling. So the advantages are they are easy to do. No need for any technical person to draw the blood from the patients. The patient themselves can pick the blood from the fingertip, and the samples can be transported to the lab. But it also has its own disadvantages, like we cannot repeat the test because the quantity of blood sample available is very less. And sometimes there is difference between the capillary blood concentration and the venous blood concentration. So how much we should go for is it to be answered properly through studies. And one more recent advance is biosensor based TDM. So here we use the principle of biosensor. So the difference in the physical and chemical properties due to interaction between the drug analyte and biological element, that is the blood sample, is used to get a signal which can be amplified to find out the concentration of the analyte to be analyzed. However, again, this biosensor is yet in the development stage. Those few studies say that biosensor prove itself to be more effective in the integration of TDM clinic because they give values within few minutes. So in the coming days, we may be seeing lots of advances in the technology to collect blood samples as well as to process the blood samples and to get the results. Okay, so far I have been telling so much about the indications for TDM, what are the applications of TDM. So what are the contraindications for TDM? It's just the opposite of the indications for TDM. So if we have a measurable clinical endpoint, then we don't have to do TDM. For example, antihypertensive drugs or anti-diabetic drugs, where we can give the drug and measure its effect by recording the blood pressure or by measuring the blood glucose level, there we don't have to do TDM. Similarly, drugs with wide therapeutic range, which can be used, for example, amlodipine, which can be used from 2.5 milligram to 10 milligram. So, like for these kind of drugs, we don't have to go for TDM. Hit and run drugs like omeprazole, like where drugs produce the effect even after they leave the body by inhibiting some enzymes permanently or irreversibly, and where the enzymes take time to get synthesized newly. So in these conditions, even if we look at even if there is no serum concentration of the particular drug, it will be having its effect. So no need to do TDM for such drugs. Then prodrugs which produce active metabolites, and the active metabolite also has got some action, and the off-life of prodrug and the active metabolite is different. In these conditions, doing tedium will not give you a fruitful outcome. So in these conditions, we can avoid tedium. So who all should be involved in doing tedium? So tedium cannot be done by a single person. It has to be a team. If tedium should be really useful in patient care for taking a decision on changing the dose to the appropriate required dose, then it needs to be a multidisciplinary approach between the clinicians, clinical pharmacologists, as well as the technicians and nurses who are all involved in collecting blood samples, processing the blood sample, reporting to the patients. So all of them should work as a team and discuss all the queries related to the value and take an appropriate decision. Then only tedium will be a successful thing. So what is the role of clinicians in tedium? They have a major role. They are the one who suspect it could be treatment failure or toxicity and send the samples. But they have to keep in mind when they send the samples, they also should know what are they looking for and what sample needs to be taken and what instructions need to be given to the patient. So that when they come to the lab, the proper sample is taken and appropriate results are given to the clinicians. And after getting the results, the clinicians should also interpret it accordingly. Even if the plasma concentration is within the normal therapeutic range, if the patient is showing some toxic features, then they should look for other things. For example, like measuring albumin level, asking for free drug level. So those things are very essential for the clinicians to ask for, and they should also be knowing about these factors and counsel the patient properly with respect to adherence. And when they send the patients to the lab to give samples, they should fill the form with all the relevant history of the patient. So what is the future scope for tedium? As we all know, tedium has not taken up much in many of the institutes. Wherever it is, even wherever it is happening, it is not at a full-fledged level. This is due to many issues like financial issues, like getting consumables, equipments, and if the equipment gets repaired, like how do we repair it, how much time it takes. So all those things have its implication on doing tedium. So if we really want to introduce tedium in our institutes, we need to conduct awareness programs through conferences or lectures or by distributing newsletters to produce awareness among the administration as well as the clinicians to bring about the significance of doing tedium. And we should always go and interact with the clinicians and tell them the importance of doing tedium in certain drugs. And our lab should be providing accurate results so that the clinicians depend upon our value and trust our value. And in future, this is an era of artificial intelligence, and there are so much scope for coming out with lots of software which can maybe deciding the next dose for the patient depending on the present therapeutic range. So to summarize, tedium is a very simple thing of measuring the blood concentration of the drug after giving the drug and then seeing whether it is in the therapeutic range to decide whether this drug will produce efficacy. Also, this is done to avoid toxicity or in the presence of toxic features to find out if it is above the therapeutic range, as well as to determine if the patient is taking the drug properly, if the patient is adhering to the treatment. These are the three major indications for which tedium is done, and we have got various procedures depending upon the institute's facility. And as far as our institute is concerned, it's regularly done in pharmacology department for anti-epileptic drugs as well as immunosuppressants like tacrolimus and cyclosporine. So I would take the opportunity to thank Dr. Manikandan, the professor and head department of pharmacology, for helping me to get the details from the lab, and Mr. Rajan and Mr. Tamirsi, the senior lab who compiling the data and shared it with me, and Dr. Shravan and Dr. Ilan, senior residents from my department, for helping me for getting the information for this topic. So with this, I will stop and ask for queries. I will be happy to take queries if you have any.
Yeah, thank you, Dr. Sandhya. That was really an extensive and elaborate talk on the DDM of anti-epileptics. Any questions from the audience? Online or offline?
Can you ask her to elaborate on the example, the first slide that she had shown?
Okay, so Dr. Sandhya, if you can go back and show the slide on the example, that's what Dr. Tripathi has requested.
I'll show. Just a minute.
And in the meantime, Dhanaya sir, if you have anything to add, we will be happy to listen to you.
Sure, please.
So Dr. S.P. Dhanaya is here with us, with Dr. Qureshi from J&K. So we really welcome you, and if you have anything to add, please feel free to add in this session. Every experience is important and every experience is worth learning from. In the meantime, let me take the opportunity to introduce Dr. Sumit. Dr. Sumit Matthew is from CMC Vellore. I requested him to join and contribute to the discussion if possible.
Thank you for inviting me, Dr. Smita. Thank you.
Pleasure, Dr. Sumit. Your session is next to mine. I just thought that let me introduce your and acknowledge your presence. Thank you so much.
Thanks.
From which example slide?
Which example, sir?
First slide.
First slide.
The first few slides.
Okay, the case scenario. Okay. Yes, sir.
Yes, this 18 microgram per ml phenytoin.
Yes, sir. Yes, sir.
So how did you actually finally got the answer to this? That was the
Yeah. I had not given that one value, that albumin. Then subsequent to this, its albumin level was measured, and it was found to be 24. And then they asked for the free phenytoin concentration, but we were not able to do free phenytoin concentration at that time. But then still, because the albumin level was low, it was suspected free phenytoin must have been high. That could have been the reason for phenytoin toxicity, and the dose was reduced. Subsequently, the patient became on.
So, but here the phenytoin range was well within the normal.
Well within the normal range, but the albumin level was lesser. He was not feeling well for the last 1 week, and he was having dysphagia, so probably he was not taking food properly. Some sort of undernourishment must have led to this low albumin level. All other parameters were normal. Complete hemogram and other routine biochemistry parameters. Only albumin level was low.
So
however, free phenytoin concentration could not be measured for this patient. But then based on low albumin level, it was suspected it could have been phenytoin toxicity, and the dose was reduced further. Subsequently, he became all right.
So, madam, this phenytoin level 18 microgram per ml, that is not corrected with the serum albumin, you mean to say?
Pardon?
No, this the phenytoin concentration was 18 microgram per ml, and that was not corrected with the serum albumin level. That's why it is low, but the free level you said it's 24 microgram per ml. Is it so? Yes. We have to correct this with the serum albumin.
Madam, can you just, I was not able to get. Madam, can you please repeat the question?
Sir wants to add that this 18 microgram
microphone is not working.
The 18 microgram per ml which has been written here, this is not the corrected phenytoin level.
Yes, this is not the correct. This is the total phenytoin level. This is not the free phenytoin level. That's what I am trying to say. We were not able to do free phenytoin level.
Right.
After getting micrograms per ml, the physician suspected. Then they checked for albumin level, and when the albumin level was low, they asked for free phenytoin level. but we were not able to measure free phenytoin level at that time. If this was some 10 years before, when we were not able to measure free phenytoin level, so could not be measured. But however, they thought this could be due to reduced albumin, free phenytoin level may be high. So empirically, they reduced the phenytoin dose, and subsequently he became alright.
So I would like to reframe it for the residents, whoever is listening to this. So the phenytoin therapeutic concentration is between 10 to 20 microgram per ml. Now we know very well that phenytoin is 90% plasma protein bound. So the free drug that is available to us is 1 to 2 microgram per ml. Now from the basic pharmacological concept, we know that the free drug is the fraction which is important and responsible for the therapeutic action. The bound form actually behaves as a reservoir, and as and when the drug dissociates and becomes a free drug, it is available for action, right? So in this case, since it is 18, you would presume that there would be around 1.8 to 2 point something, 2.6 or 3.6 should be the concentration. But here the catch here is, if the phenytoin is more than 90% bound and you have less than 2.5 milligrams per deciliter of albumin, there would be much more phenytoin available as free form. And this free form is responsible for all this CNS effect this patient was demonstrating, right? And therefore, like Madam said in the form, there are several details. Sometimes the forms are not adequately filled. If you see a level of 18 and the patient is showing you signs of toxicity, you will be confused. It's all good. But you have to ask proactively, what is the serum albumin concentration in this patient?
No, I think here lies the importance of interpretation and the comment from the clinical pharmacologist.
Absolutely.
In this particular case, okay, although the free phenytoin estimation system was not available at that point of time, but if it comes from a clinical pharmacologist's desk that this is the possible reason, with the reasoning, then that can assure the clinician.
Absolutely, sir. So free phenytoin estimation is a very tedious process.
Right.
You need to do the microdialysis, you have to keep the sample incubated overnight, and then you need a very sensitive method to go back and detect that 0.01 to 0.4 microgram per ml. Our systems, the HPLCs, are good at 1 microgram to, let's say, 50-60 micrograms. So therefore we don't perform the free phenytoin concentration unless the albumin is low. We assume that it is the total drug concentration which will guide us to decide the therapeutic range.
I think we need to appreciate that why this particular case was sent for TDM. Okay, the problem was it was within that apparently normal range.
So the clinical signs and symptom of toxicity.
Absolutely, the clinician was seeing toxicity of phenytoin, while apparently there was a normal range. So that is the reason they had sent.
Correct.
So when this was done, the phenytoin estimation was done, it was found to be 18. Then the interpretation, clinical pharmacological reconciliation and interpretation, that should go. Okay, that's why it is again and again said, it not just measuring, but also the monitoring. The monitoring is actually this interpretation and proper report, okay, from the clinical pharmacologist.
Okay.
Thank you.
So we'll move on, sir. There is one question in the chat box. How do you do TDM on biologics, Dr. Satyavrata Sahu?
Yeah. So as such, right now we are not doing the TDM of biologics. As I already mentioned, we are doing TDM of anti-epileptic drugs and immunosuppressants, namely tacrolimus and cyclosporine. We have restricted to this thing only, and this itself takes most of the time of the lab. Weekly, twice it is for tacrolimus and cyclosporine, and once for anti-epileptics. Tacrolimus will be done on the same day because these are renal transplant patients and the dose has to be modified accordingly within a day because the patient comes from different places for just doing this tedium. So this will be done on the same day, whereas for antitryptic drugs, they will wait for the samples to collect some 10 samples to run one HPLC or UPLC. So it takes some time. We have not entered into the tedium of biologics as of now.
Right.
As such, I don't have experience on
nor do we have experience, but being a part of this International Association of Therapeutic Drug Monitoring and Toxicology, I get to hear from my colleagues there about the etanercept and other drugs. Apparently, some of the inflammatory bowel disease patients, they have found that this is really determining the response. But to the best of my knowledge, I haven't seen any of, I haven't come across any department doing it in India, but anybody can correct me if it is being done in India.
Hi, thank you for the question. Basically, I would like to comment on this.
Sure.
And the previous question regarding the phenytoin. So, one is the availability of tedium for biologics. It is available in India. It is available. Whether people are using it is a different question, but it's available in India. So there are two ways of doing biologics tedium. One is the easiest way is by using ELISA methods. So for example, immunoassay methods. So immunoassay kits are available in India, which we can actually use it for tedium of biologics. The second option is LCMS. But LCMS is a more tedious procedure where you have to digest the big biological molecule, and only a small part, which is the key for that. So basically a small part of it, peptide chain, will be analyzed. But that is a tedious procedure in MS. So the easiest way to do monitoring of biologics is by doing immunoassay kit method. Now, the previous question about the phenytoin, I would like to address here the important reason why we pharmacologists are supposed to play a role in doing tedium. So here we have a procedure room in CMC Vellore where we actually do procedures related to tedium. We have to collect a lot of information before you actually take a sample. So in the example of phenytoin or rifampicin, one important information that you need to collect even before doing the analysis is you have to see the albumin. Okay, so if you actually see the albumin and if it is low, then you have to account for it when you actually give a result. So now for phenytoin, as you all know, there is an equation called Srinathosar equation, which is used for correcting if there is hypoalbuminemia. You have to use that equation to correct the phenytoin that you are measuring, and then only you report it. So otherwise, you have to go and do the free phenytoin level. Free phenytoin is the best way actually to do phenytoin estimation. Okay, so the important role of pharmacologists here in TDM is we have to collect information before a sample is taken from the patient, and that's an extensive process. And that is why the TDM is very different from a simple biochemistry test. A biochemistry test, you can just send a sample to a lab and the sample can be analyzed there. But when we are doing TDM, you have to collect a lot of clinical information before. It's like doing pathology specimen test or doing a pathology slide examination. You have to know a lot of history before you actually do the TDM. So I hope I am clear with that for phenytoin. So obviously, just going by range always will not help. Make sure that you are getting the information correct before you do the collection of sample. Thank you.
Thank you so much, Dr. Sumit, for those two important points. And I would like to ask, which platform does the biologic TDM, or it's an open-ended kit?
There is a company which provides kits for biologics, Nova Diagnostics.
Those are simple ELISA plates?
Kit-based method, immunoassays.
Okay, so
Immunoassay kit-based method.
if you have, let's say, 4 samples today, would you be able to perform that in those? It's a 96 well plate.
I assume so. I have not used it, but those people actually came to us and they said it's available. You can start the test. So that's how I came to know all that.
Wonderful. Thank you for that information. We have been struggling with the small molecules. We haven't ventured into the biologics so far.
Okay.
Right.
Okay.
Also, in any way with antibody assay, anti-drug antibody assay.
Yes, sir. It's a ELISA-based technique. I'll show you some of the things. So, Dr. Sandhya, thank you so much. Thank you so much for that presentation. You may stop share so that I will be able to share my screen.
Yeah. Thank you, madam. Once again, I thank organizing
Thank you
team
so much
giving me
for
this opportunity.
accepting that invite in such a short notice. We would have loved your presentation in person, though.
Yeah, I also was thinking of coming. Due to some other reason, I could not come. Yeah, thank you, madam.
Thank you. Okay, so let's quickly start with mine, though I had some of the anti-epileptic data from our center to share, but in the interest of time, I'm just refraining from that. If we have time in the end, maybe during the discussion, I can project those slides. We just concluded about, we did an audit of 950 patients over a period of 5 years at our center for the older anti-epileptic drugs, and I would have loved to show that data, but nevertheless, let's move to the next topic. For the sake of, I would say, to keep it basic and simple, basically this presentation is mostly meant for an MD student who has no knowledge about the TDM of immunosuppressant drugs. Unfortunately, very few centers in India are performing this. So,
Can I just ask because I'm interested in history. So, I suppose the TDM service in India at least, KEM had a lot of role. It was, I think, 1988 they started.
They started.
What about PGI? When did it start?
We started
PGI?
in 1991.
91. Okay. So for all
Or
practical
90.
For all practical purposes in India, 88 is the
Yes.
when TDM started.
That's
in
what
India.
is my information. Sir.
As per the literature goes.
Yes.
So it is 1988. I think. Okay. And then 90 is PGI. Okay.
Dr. SK Garg
91, I think, sir, CMC Vellore started, if I'm not wrong. So, Dr. Sumit, you may correct me if I'm giving some misinformation.
No, we started very late. We started very recently compared to that. So we started in 2004. 2004.
But
Yes.
to the
We
best
had a
of-
clinical pharmacology lab even before that, but TDM was started in 2004.
I see.
Yes.
So these are also interesting bit of information, tracing the history of TDM in India.
Right, and sir, I must acknowledge this, that we started in 91. We did not make much progress in those. After a decade, we did not make much progress the way we should have progressed in our center. I say we because I grew up in that place, so
Yeah,
it's been.
It's not 90. It has to be 91 because I remember while we were there, there were a lot of talks about very soon it will be started. I left in 91.
So 91.
So it may be right then it all started with Dr. Garg.
With Dr. Garg.
Right. Okay.
So I would presume that should have been we could have made better progress, but nevertheless we tried catching up about a decade back with the world
Right.
and with everyone else. So now we really are making fast progress. But there's a long way to go, I must
Right.
say.
Okay. Correct.
So, to the best of my knowledge, CMC Vellore does a very wonderful job. I mean, I am really I'm very proud of saying that the kind of work they have done so far, and the kind of work they are doing. They also run a fellowship program for everyone else's information. Those who are interested in taking it post MD, this program is even open for the non-MD graduates. Dr. Sumit, is it so?
No, it's
No.
only for
MD,
pharmacologists.
okay.
Yes.
Right. And this is a 1-year program, if I'm not wrong.
It is. We started as a one-year program.
One-year
Yes.
program.
1 year.
So anyone who is interested and wants to pursue this area is CMC is the
Welcome.
place to go, definitely. Okay, let's move forward. So where are these immunosuppressant drugs used? Mostly we know that it's organ transplantations. It is the solid organ transplantation, hematopoietic stem cell transplantation. And the other major area is autoimmune diseases, where we know that we have to lower this is the basic two broad areas where we see that these drugs are being used. So these are the non-transplant settings are glomerular diseases, several you would have seen the vasculitis, SLE, inflammatory bowel disease, autoimmune hemolytic anemia, etc. Now, so these are the drugs which we use. We use mostly the calcineurin inhibitors, cyclosporin A, tacrolimus, antiproliferatives, that is the mTOR inhibitor, which is sirolimus and everolimus. And to your information, mostly a TDM run, which is run by the LCMSMS method, we try to club cyclosporin, tacrolimus, sirolimus and everolimus in one run because of the basic nature of these compounds being similar. Now we have antiproliferatives, that is mycophenolate, which is a IMPDH2 inhibitor. Now the other four, you may notice that I have grouped them separately. That's azathioprine, steroids, antithymocyte, globulin and belatacept. So these are drugs which are being used, but TDM has not been the standard of care for them or not been practiced. So like Dr. Sandhya said, you have to understand where TDM is not useful. For let's say antithymocyte globulin, we have got something like a rabbit monoclonal antibody which has to be used against the CD3 to kill the T cells before the transplantation is being done. So in this case, the better biomarker we have, that is the CD3 cell count, which is easily doable. Why take the pain of measuring a biologic? Now next, coming to the azathioprine, we really don't do the TDM, but we do some of the 6-guanine compound estimations, but these are mostly in connection with the TPMT and the NUDT polymorphism in which we need. So mostly the TPMT and the NUDT polymorphisms are being done in the tertiary care hospitals. And some of the 6-thioguanine compounds are also being done to give an indicator that you might have a polymorphism that is affecting the metabolism of this drug. So at our center, we don't do routine monitoring of the drug. However, whenever the patient actually lands up in a neutropenia or a pancytopenia, we get activated and we go and frantically get the genotype done. So the clinicians believe that very few patients land up with this adverse event, and then most of the time it is salvageable, so we routinely don't perform it. And the other thing is steroids. Steroids are kind of the ubiquitous the immunosuppressant that's being used. So in which we generally don't monitor their thing. We only monitor the dose and the clinical response. Now the other drug is belatacept. Belatacept is a co-stimulation inhibitor. Again, a biologic has to be administered by injection, subcutaneous injection once a month. Again, a biologic, the TDM, there are papers about belatacept TDM, but the processes are not the established, and the TDM in clinical practice is not well established. So why we for immunosuppressant drugs, why do we really need TDM? As Dr. Sandhya very rightly pointed out some of the points, that if your kinetics is very well correlating with the clinical response, and you can titrate those responses, you can prevent toxicities when your drug is of low therapeutic index, etc., etc. So in the context of immunosuppressant drug, when we're using them in clinical practice, it's like walking on a tight rope. Like this person, you can see, you just imagine you're using an immunosuppressant drug and you are a doctor and you're like this. So are the TDM professionals. So you end up facing consequences of insufficient immunosuppression or over immunosuppressed patients. So this is typically from a renal transplant perspective, that this slide, but this is nevertheless is the universal truth, that you may have therapeutic failures, your immunosuppression is not adequate, or you end up having a lot of infection, nephrotoxicity or end organ toxicity, I should say, and all the metabolic side effects like hypertension and diabetes, or I should say deranged glucose metabolism. Okay, so now the immunosuppressant drug typically fit into these four group, with two things that I am adding here is high interpatient variability and high intrapatient variability. These are very well known observations about the immunosuppressant drugs, and therefore if we see the number of requests that any center who does a myriad of drugs and delivers a service for or TDM service for a myriad of drugs, immunosuppressants will dominate the list. So and out of these immunosuppressants, let me be very honest, tacrolimus is more than 90% of the requests. Okay, so for the residents, it is interpatient is between patients, and intrapatient is within the same patient. So you may have different levels for the same dose in a patient with different absorption profiles. Let's say one day patient took food, the other day he is maybe having some underlying infection, the other day the GI motility was not appropriate like the previous day. So these are the reasons for intrapatient variability, and sometimes the causes are really unknown. And for interpatient variability, the pharmacogenomics of the patient is the one which plays a lot of role, especially in the context of tacrolimus, which is the CYP3A5. We'll see some of them. So cyclosporin, those are that's the first immunosuppressant as such for which TDM was introduced. You know, the first transplantation was actually done with azathioprine and corticosteroids. So after the introduction of cyclosporin, actually the scenario for organ transplantation changed. The rejection rates were reduced by more than 50%. When earlier days we used to have rejections 80%, now it reduced to somewhere around 30%. So this drug got approval in 1983, and the first formulation actually was in 1983, which is the Sandimune from Sandimune, which is a formulation of cyclosporin which had a bit of absorption issues. So the initial absorption was not very good for cyclosporin when it was launched. Then the neural formulation or the microemulsion formulation came in 1994, launched by Novartis, and so this is practically one of the first drugs for which the immunosuppressant drugs for which TDM was done. So the next drug I'll be just giving an overview. That's 1994. The same year the cyclosporin new formulation was launched. The first indication was actually in liver transplant, and then kidney and cardiac followed. So as I mentioned, more than 95% of the immunosuppressant that is used in the solid organ transplantation is tacrolimus. And cyclosporine is particularly popular in the hematopoietic stem cell transplant. You might question the thing that when we know tacrolimus is more sort of efficacious, why are we using cyclosporine in the first place? But nevertheless, this is kind of a, this concept needs some sort of clarification. Cyclosporine and tacrolimus both have their inherent limitations. Tacrolimus gets absorbed very fast, but it's very efficacious as well as it's very toxic also. So at the same time, you might have better regulation of cyclosporine levels. Cyclosporine levels generally do not fluctuate much. The pharmacogenomic effects on cyclosporine A is limited, and the clinicians who have been using both the drugs, they feel that it's way easier to control and manage a patient on cyclosporine than tacrolimus. However, we know that the evidence for the efficacy of tacrolimus is better. You can see that the better graft survival is seen with tacrolimus. And as well as I told you, it comes at a higher cost of diabetes, tremor, and all these adverse events, gingival hyperplasia, dyslipidemia, etc. So both the drugs have their advantages and disadvantages, and both are in use in different contexts, in the sense that the predominant use of cyclosporine is in hematopoietic stem cell transplant and tacrolimus in solid organ transplants. Now, if I'm going back to the TDM of cyclosporine A, it's C0 versus C2. So why C0 versus C2? C0, Dr. Sandhya explained, is the trough concentration, but C2 also came up for cyclosporine. So C2 actually came up for the neural formulation or the microemulsion formulation, which has a delayed absorption. And some of the conventional preparation of cyclosporine also studied the C2. However, the TDM community is yet not at a consensus which one is the better biomarker. For all practical purposes, C0 is being used. I remember somebody in the last TDM education class asked this question. I went back and looked up, and I really stay on my answer that I'm kind of close to the truth, that there is no consensus about C0 and C2. For all we know is C0 is the time-tested marker, though some of the studies really say that C0 may not be an indicator of efficacy or long-term outcome in these patients. But we all do C0s for cyclosporine. So some of the clinicians in my setting, my institute, believe that C2 was a Novartis floated concept for microemulsion of with all due respect to the industry. So C2 was a Novartis invention, but at present everybody does C0. Now TDM of tacrolimus, we know that the sorry, I missed a little bit here. So the when you are doing C0, the C0 is 200 to 300 in first 1 to 3 months of transplantation, 50 to 150 in the later months. So one thing to take away from here is the levels or the therapeutic window varies from with the time since transplantation. So for C2 it is 800 to 1000 and 400 to 600. So just mind you the ranges. So it's pretty wide for cyclosporine in comparison to tacrolimus, where it is like 7 to 10 in the early months of transplantation and 3 to 7 in the subsequent months. So in the West, people practice it as with ATG or without ATG for a solid organ transplant. And so I'll just quickly move forward. So this is the personalized therapy consensus report, where these are the takeaways from here. So the pre-dose C0 is still the best. The They do recommend the exposure for patients who are having high risk, who are in the high risk category. And a group in the France is working on this. University of Limoges has proposed that AUC by C0 probably stays constant for a particular patient, and for high risk patient you would probably like to do an AUC, as C0 may not be the best indicator. Now here they emphasize in this document the importance of consistency, calibration, proficiency testing, and requirement of standardization, and the reference material that is being used. So these are all part of the quality parameters, and Dr. Sandhya already elaborated this. So the most important part is to maintain that quality, and even though we are not accredited, we should be knowing that what we are doing is the right thing, and we are as much close to the truth as possible with the limited setting in which we are working. So the CYP3 genotype, this document also mentions, and then it also mentioned the residual nuclear factor activated T cells. This is for tacrolimus. So this is the target, the pharmacodynamic target. Since I am sitting in the, I am in the company of the pharmacologist, I am trying to go a little bit to the lab. Okay. Now, how do we test these immunosuppressants? We started in our center in about I think 2016 we started. 2015 or 16 we started with the LCMS-MS. Pediatric biochemistry actually procured the LCMS-MS. We were closely involved because that was the first LCMS-MS we got in our institute. And now for last 1.5 years, we were running into trouble with the LCMS-MS with the high turnaround time, and because the one instrument was being utilized for the newborn screening as well as you know, it's a very versatile equipment. So multiple users, and therefore the turnaround time for drug reporting was high. So we procured another autoanalyzer, and our reporting time is within 2 hours or 2 to 4 hours of receiving the sample. Now, you see when we fight between, I mean, there are great discussions whether this assay is better or the mass spectrometry is the better one. So I will just take you through some of the things, like we have the pros and cons of each method. So here, please pay attention to the upper panel, which is the, like we were discussing, this is for the residents. Like we were discussing the ELISA methods, whether it's a direct ELISA, indirect ELISA, or sandwich ELISA or anything. You have all types of method existing for the drugs. For a biologic, you might go for a sandwich ELISA kind of a method. This is depending on how the kit is being developed by the vendor, and what is coming out as a more error-free and very validated thing for a specific test. So this is a very it's very easy to use. The acceptance quality controls are good if you keep all your checks and balances in place. The cost of equipment is less compared to the LCMS-MS. The throughput is fast. Like our equipment can process around 450 samples per 1 hour. Now we don't get as much samples, but this is what is the processing speed of this equipment. And then the sensitivity. So sensitivity means how low you can detect the compound or the drug or whatever your analyte of interest is. So typically sensitivity in this instrument, the autoanalyzers are up to the tune of 2 nanograms. So we don't consider them a very sensitive equipment, because we have the LCMS-MS, which is the gold standard. Okay. Now the disadvantage of this immunoassay is it has a problem of selectivity. You see, this is antigen-antibody reactions, and if you have a mimicker, which could be anything, which could be a metabolite of the drug, which could even be an endogenous molecule, which could even be a another antibody which is having a similar structure. So selectivity or non-specificity is the problem in these assays, and therefore the general understanding is that you always get a little higher value than the accurate value or the exact values, and we cannot go away from the non-specificity here. And the sample volume that is required for this assay, immunoassay, is generally higher. I'm just telling from experience that 200 microliter we require for an immunoassay method, whereas an LCMS-MS method can do it in 50 microliter. So it's a 1/4. Then cost for sample is high in an immunoassay method. So if you end up using we call it as a closed system or an open system. So closed system is when you have to buy the kit from the vendor who has supplied you the instrument. And most of the times it goes like that because the vendor otherwise does not take the responsibility when the quality of the test is not maintained. So you most of the times end up having, because if you're using an open-ended system, when you buy a kit from a third party, then the onus of accuracy is actually on you. Alright? So we all end up using the closed systems. So therefore the cost per sample is high. So even if the equipment cost is low, the cost of analysis of each sample is high. Therefore people have made elaborate calculations, and they have seen that when you have a high sample load, your hospital is having, let's say, 300 samples per day, then LCMS-MS turns out to be economical compared to an immunoassay. Provided we are not here talking about the turnaround time. Time is money, everybody knows, but we are not talking about the turnaround time here. Okay. Now the next point I would like to highlight is the reproducibility. Now reproducibility in these assays are generally considered inferior to the LCMS-MS because you might have variations in the temperature of the lab. You might have a change in the way the sample had been stored, and there is clogging, or there is how do I explain? So there is several antibodies have stick to, and there's a loss in the sample that you are taking. So generally these are considered inferior in terms of their reproducibility compared to an LCMS-MS, where you are choosing your sample, the sensitivity and the accuracy, everything is better than the immunoassay. Now multiplexing is something that I told in the beginning. We try to club all 4 immunosuppressants and then try to run one method so that you may have any type of sample, but in the one run that you can report. So that actually is very economical for the lab. The more you multiplex, the better it is. But in an immunoassay method, the scope of multiplexing is non-existent, because you can't possibly put 2 types of antibodies and do 2 types of estimation in one well. So next is the mass spectrometry. So mass spectrometry is much better in terms of sensitivity, specificity and multiplexing that I just discussed. The disadvantage in terms of the mass spectrometry is the most important is the handling, because it is very much technically demanding. You have to have an expert who would realize that there is some error somewhere. Otherwise, in that you may remain in that sense of grandeur that I am running a LCMS-MS, nothing can go wrong. When you are not technically sound or you have some error in your assay, the analysis can really go haywire and you end up concluding wrong things. Inaccurate estimations would then be a standard. So the other thing is lack of standardization. So there are great documents from several regulatory agencies for standardization of the assays and the periodic monitoring and things. So most of the times the standardization, the onus of standardization in a setting where there is no regulatory body or regulatory authority looking at a clinical lab, actually the onus is on the lab director himself or herself. So in a regulated environment, or in an environment where you are doing reporting in a CLIA setting or a accredited kind of a setting, then the standardization protocols are well maintained, and they kind of assure that the lack of standardization is not the case for this sample. So the other thing that I would like to highlight is the matrix effect that we see in these cases in the LCMS-MS. So different types of biological matrix may have interferences, and you have to rule out matrix effect when you are standardizing in assay. So the question, we come back to the question, which is the best? This is the take, that is the general consensus. The no single method immunoassay or mass spectrometry is the preferred method in every situation. Lack of assay standardization is currently not specific to one assay type, so you might have lack of assay standardization also in the immunoassay, and the implication of this should be carefully considered for each specific assay. Then I would like to really read, because each word is important. When deciding between immunoassay and a mass spectrometry for your lab, the best option will depend on your lab's needs, goals, and the patient population. So next drug is mycophenolate. I will quickly browse through this because we are we don't want Dr. Sumit to be waiting for a longer period. Now this is the basic thing about the drug. I just made this slide to give an overview of the drug, because it might seem to an unrelated audience who is not working in this area very alien. So mycophenolate is IMPDH2 inhibitor. It gets metabolized to MPAG, mycophenolate, and the active moiety that we measure is mycophenolic acid. It is available in two formulations, MMF and the ECMPS. Again, second formulation came up because of some criticism of the MMF for gastric toxicity or gastric adverse events intolerability. Now, enterohepatic circulation is something every pharmacologist should know. So, all the students, please pay attention. This is the keyword for mycophenolate. That's one thing that I would like you to take home. Mycophenolate has significant enterohepatic circulation. Thereby, I mean that there is going to be a second peak in this. Therefore, the current consensus is that C0 is not an indicator of it's not a good PK biomarker for TDM. So what do we do here? We do a AUC. So for doing an AUC, you can see in this picture how many samples have been taken? 3 to 5, 8. 8 samples have been taken. So for each patient, you have to take 8 samples. Is that feasible? And is the patient going to get it done for you? I would not get it done. I don't want my mycophenolate to be done. You choose an alternative drug for me, even if mycophenolate is the best kind of antiproliferative. Because azathioprine, we see patients coming back to us with leukopenias. You would not see, mostly mycophenolate is generally well tolerated. So for GI side effects, they would just reduce the dose. I would not go for an 8 sample test. So what do we do? In this document, we sort of propose that this is the overview of the document that say from the IIT-DMCT says that AUC is definitely the biomarker, but you have to work around that. You may have limited sampling strategies, but the flip side is you have to do it in your own population, and you can also go for Bayesian dose adjustment, which is like a statistical way of extrapolating from 1 or 2 samples the 12-hour AUC of mycophenolate, and the fixed dose prescription, because this is always titrated, and because the TDM is not frequently done in many parts of the country, so the fixed doses are prescribed, which has been really questioned. And the range here, the therapeutic range we are looking at for the AUC is 30 to 60. And one point a practical point I would like to highlight here is HPLC turns out to be as good a method, as good and accurate method, I would say, for doing the mycophenolate, because you measure them in micrograms per ml. So it turns out to be really well as accurate as the LCM-SMS method. So that's where I would like to stop, because Dr. Sumit will take on the next. If anyone has any questions. Yes, please.
Ma'am, could you just explain the cost aspect of the kit asset, like immunoassay drug screen? It is the cost is higher per sample, but overall low. I could not.
Yeah. Overall, it is not low. Overall, cost of equipment is low. Let's say the cost of equipment is 15 to 17 or 19 lakhs, but the kit that we get for the kit will have the diluents, the extraction reagent, the buffers, and the QCs and the standards. They would be somewhere around 20 to 50,000, in which you would be able to analyze some randomly around 300 samples. So we provide the test at a cost of 500 rupees to the patient, but again that's a highly subsidized one. So in outside labs would charge somewhere around 3,500. Anyway, most of the patients who come to us are having either the Ayushman Bharat beneficiary or poor free. We make them poor free when they are generally the BPL, the below poverty line kind of patient. So don't look at that 500 rupees as a cost. You end up spending somewhere around 1,000, 1,200 if in a non-profit, non-loss kind of a thing.
Thank you.
And the interesting thing is, some of the equipment vendors, I would like you to know this fact as a lab director, the equipment vendors are always eager to give you the equipment free of cost. Why? That's because you will buy the kits, and that's how they will make up the cost. So in PGI we do not have a policy to take like that, but if you can really afford one, why not? It's ultimately for the patient.
Thank you, ma'am.
Yes, please, Dr. Sani.
Fantastic work that has been showcased. One of the big learnings that I had during my time in KEM in Mumbai was the beauty of using real world data as well as pharmacoeconomic data. Pharmacoeconomic data in order to showcase the results to the authorities, right? And I think many of the times the institute director and the institute governance body actually always asks us, because why do you want to have TDM? Why do you want to have a space? Can we use this space for something else? I mean, that's always the question that comes back. So what has been your experience in driving these conversations?
Wonderful. So that's a real difficult question actually. So we did some of the pharmacoeconomic things, but as of now, it's always the patient welfare that dominated so far. We can't make a general assumption that this system would ever be profitable, and because if I go back and look at the statistics, as I mentioned, almost about 60% of our patients are poor free.
So maybe I think I'm asking the wrong institute this question.
Yes, I'm sure it's your tax money, it's my tax money, it's everybody else's tax money where it is going.
Correct.
But we certainly need an assessment there that how much the institute is investing for one test.
Yeah.
Which we actually haven't done a formal calculation, which would include all the investment, establishment,
Yes.
manpower, everything else.
Correct. Yeah. And more important, what is the benefit that the patient gets, right? Ultimately, it is not just the test result for one patient, but for the community, what is the value that they get from it?
Excellent point, but excellent question, but with no easy answers, I must say, because these kind of studies are completely lacking. We recently just published a article in BJCP where we have said that there should be a continuous assessment of a system, in the sense that we are establishing a service. At the end of the day, the outcome studies are completely lacking. A group where TDM was not done, a group where TDM was done.
Correct.
These kind of studies are unfortunately lacking from most of the parts of the world, even in the developed countries. And making an RCT work in a TDM setting is almost impossible.
Maybe you wouldn't have to do an RCT per se, maybe a simple observational or you could follow the same.
So when, let me know, when there is evolving evidence which suggests that TDM is beneficial, how will you not do it, even for an immunosuppressant drug? It would be disastrous not to offer a TDM, not assessing tacrolimus level in an organ transplant patient. So I'm really looking forward to an answer. How will you conduct those kind of studies where you would say that you would not do TDM versus you have done TDM, and what is the result?
Good point. I mean, even I don't have an answer.
No, we all need to find an answer for this. I mean, how will you design such a study? You're very right that you should have observational data, but we would like to have an historical data set where when TDM was not practiced. And if you have an historical data set, the clinical practice has changed so much. The surgical technique has changed so much. Even for, the hematopoietic stem cell transplant, things have evolved over a long period, decades.
Yeah.
So, we really need to find a design of a study which would assess this. We can have a lot of retrospective data where because most of the evidence comes like, okay, the patient had higher concentration and he landed up in adverse event, or lower concentration he ended up having GVHD or anything, or a graft rejection. I am not sure whether I have an answer for your question.
No, thank you. Let's take this offline as a conversation, but I don't want to hold up the other conversation.
Thank you for that question though. Hello, Dr. Sumit?
Hi ma'am.
Yeah. Anything you would like to add? Dhaneria sir, would you like to add anything? Okay, so Dr. Sumit,
I will address this issue regarding the study in my talk.
So if you permit 5 minutes, can we quickly, my student actually dealt with this case, and if you permit, can we quickly do this case presentation of a patient where we used TDM plus pharmacogenomics to quickly 5 minutes. Kumarvel, can you please come up and present this?